This pneumothorax, pneumothorax.
Hello, everyone.
Hi, Arif. How are you?
Thank you very much. You okay?
I'm good, thank you.
So, look, I did a couple of scans.
Yeah.
We actually, honestly, didn't find chance to do on sick babies. They were just well babies. I just quickly scanned them, only one view, uh, and I uploaded them on Dropbox.
Yep. I've had a look at them. They're good images. The quality of the images is good. I think the few things that you might want to look at are your depth and the settings. And what I would suggest is that if we can kind of do a one-on-one at one point. So I just need to know which machine you're using and which probe in terms of
Right.
the kind of frequency.
Okay. Fine. So this was GE machine,
Yeah,
and I used the linear probe,
you
not
use
the
the linear probe.
the linear.
Okay, what in your images, it's a little bit tricky because I can't quite see the frequency. So when you have your images, it's just worth put it in the PowerPoint when you save them, is
Okay.
just putting what frequency you're using, because then I can give you a little bit of kind of advice on, because you're losing the lower half of your screen.
Right. Okay.
And that
Okay.
kind of gives me the impression that you might be using a high frequency
Mhm.
in a term baby, which kind of means that you tend to focus on the superficial area. The GE machine is beautiful. You do not need to adjust focus at all.
Okay.
So
Okay.
you would basically alter and get into deeper parts of the lung by adjusting your depth, and the risk of going too far in, especially if you start using depths of in the range of 6, 7 centimeters, like they do in adults, is you will start, the sound waves will just unfortunately not reflect back from the deeper areas, and you get this kind of area of, I would say, gray, which doesn't kind of give you any information. So the risk with that is you miss deeper consolidations where the pleural line is altered, or potentially, if you have an area of atelectasis, again, you might see the pleura is not visible, but you might miss that. So best thing to do would be for, do you know which GE you're using? Is it the 95?
I don't have on top of my head now. I have to
Take a
check.
picture, take a picture of your machine and your probe, and I would encourage everybody who is going to be part of peer review uh, to just give me a little bit of an idea about your image. So you can individually PM me, and I will save that in your folder. When I have a look at your images, it just gives me an idea of how I might be able to advise you to image optimize.
Sure, sure, will do,
Lovely.
definitely. Thank you.
Just while we're waiting for Dr. Ashraf to get the file, Surjit, do you have a case?
Yes, Dr. Alvam. Yeah.
Can you share?
Should I share?
Yeah. So just one thing,
Yeah.
Surjit, are you able to put your camera on? Is it
Yeah, sure.
lovely? Thank you so much.
Hello.
Now you can use the share button.
Share screen.
Yeah. Amazing. So this is perfect, guys. Surjit is giving you an absolutely amazing example of how you might want to share your cases going forwards and how we'll do peer review.
So this is, I think Dr. Ashraf has shared.
Okay. Dr. Ashraf, have you shared?
Yes, I will start. Well, what?
Okay, go for it. Okay. Surjit, you can do the next one.
Yeah, sure.
God bless you. Thank you. Go for it, Dr. Ashraf. We would just, yeah.
Good evening, everyone. Today I will present the first case of pneumothorax.
So
The background, the
you,
background with this baby.
Dr. Ashraf, you want to go into slideshow mode? Yeah, beautiful. Lovely.
It is early term male neonate, 38 week, delivered by normal vaginal delivery, unbooked mother with prom 27 hours, post left aortic congenital aortic hernia repair. Use lung ultrasound at third day of life to assess the lung after repair of the left diaphragmatic hernia. This is image. I share this image because the normal lung. This is the wait. You see nicely rib will between sign, between sign. This is broad line. It is smooth with careful linear. With normal A pattern. This is normal lung ultrasound pattern. You see the line sliding, everything.
Dr. Ashraf, which machine are you using?
Yes, you use GE 55, IQ 5.
So you're using the IQ5. And just in terms of your
Yeah,
probe, this is a linear probe.
linear probe 12, yeah.
You're using a 12. And just the frequency you're using is a 12, is it, at the moment?
5 to 10.
Okay, yeah. Okay, that's fine. Go for it, yeah.
This is L1.
Barcode sign.
Yeah. So first one. There is here no lung sliding. By M mode, this is barcode sign.
Yeah. Lovely. Beautiful.
There is no this is track sign. This is normal pleural line with normal air, but there is no lung sliding.
And you can actually see a lung point there.
It can be this area.
Yeah. So just it's a beautiful image. Should we go back to your first image, Dr. Ashraf? It's because it's really good teaching point.
The first one, normal
First,
lung.
the normal lung, please. Yeah.
Yes. This one.
Perfect. Yeah. So if we just play that, so you have a beautiful image here. This is R5. And just to give you a little bit of an
Same.
idea that
Yeah.
with R5, the challenge that you have is the back of the baby. And I'm assuming this baby is prone at the moment or you sideways?
This is another baby, normal baby before, but I get
Sure,
this slide because this is beautiful image.
sure, sure. So
This is not the same baby.
yeah, just to give people an idea, it's quite difficult when you're looking at the back because there's a lot of soft tissue interface. You have the scapula on
Yeah,
either side. So with a
yeah,
linear
yeah,
probe, getting it straight can be challenging. Now, the challenge here is because we're slightly aligned, what is happening is that your A lines, the reverberation artifact that you see, and I'm just going to demonstrate it on the screen here. So the reverberation artifact that you see over here, it's kind of, they're not really in one line. They're relatively interspersed. And it's because of the probe alignment. Now, as the probe is aligned in that direction, what is happening is with your depth, you're losing out on the deeper image. And
yeah.
with a GE, with the vivid, the focus, and I'll rub everything out. Yeah, you can just go to the previous slide again. Yeah, the focus in this usually is adjusted at the level of the pleural line uh, in old machines, but in the new vivid, really you don't need to adjust focus at all because it tends to basically work by optimizing the image quality at each level. Now, depending on the probe alignment. So really what I'd say in situations like this, if you want to get better, deeper images, you might have to reduce your frequency a bit. So if you're using a frequency of 12, you might want to bring it down to 10, which will then give you better depth and a better analysis of the deeper image. This is perfect. This is beautiful. There's absolutely nothing that I would do to want to image optimize. But just to say that for people who are, and a lot of people will use the GE, we'll talk about the Philips as well. Carry on, sir. We just go to your next image.
Yes.
So this is a beautiful image.
Again, yeah, it is, yeah, it is, projectile science, no lung sliding.
So
And this is lung boy, this one here is one that is sliding here.
yeah, that's true. So you've basically got the heart coming in over here.
Yeah.
You have no lung sliding over here. Now, just the most important thing is Dr. Ashraf is a very, very experienced scanner. I mean, I can see that from your images. And so for everybody, I want you to get into the habit of using this protocol. You must get into the habit. I use it to date. I never deviate from it. And the first thing I always describe is I can see a batwing sign. I can see at least 3 intercostal spaces with 4 ribs, and then describing basically the pleura. And classically, what Dr. Ashraf has described really nicely is the pleura is sliding here, but there's no sliding here. And what you classically see is the mirror image rib sign, which is the truck sign, because the pleural surface here with air in it is incredibly reflective. Because of the high reflectivity, you're getting really nice accentuated ribs. If you could just play the image again, sir, that would be so kind of you. It's a beautiful image. Now, I think my compliments to Dr. Ashraf. 3.5 centimeters of depth with very good image quality. In a baby who has a decent pneumothorax anteriorly with a lung point, I mean, you can't do
Yes, sorry.
better than this. I'll just rub it out so everybody can see the image. This is, beautiful. Carry on, sir. So you've got a lovely barcode sign there.
Yeah, this barcode sign. You have here no lung sliding.
Yeah,
This is with M mode, you have barcode sign.
yeah, beautiful, sir. With very good depth, 3.5 centimeters. Yeah,
There's the same, no lung sliding. You have now batwing sign, drape, and this drape, and the track sign, or rib. No lung sliding here.
yeah, very good. So can I ask somebody, anybody in the group other than Dr. Ashraf, if you could just play the image again?
Uh,
You've gone to the next image.
Next presentation, I will make it repetition for
Okay.
the believe repetition. Yani, no
Sure,
need
sure.
to do everything.
Yeah. So can anybody tell me what this is? Right in the middle. Anybody?
This is mirror drip.
Truck sign, the
Yeah, it's
truck
a truck
sign
side. Very good.
mirroring the
Very
body.
good. There's something else there as well, but maybe that's for later. No problems. Carry on. Carry on, Dr. Ashraf.
This is also barcode sign.
Yep.
This is the heart beat.
Yep.
Because after the fluidic repair, they have some blood fluid
Yep.
here.
Yep.
This is left side. This is spleen, and this is the one the diaphragm, new diaphragm,
Yep.
and this is the fluid. Anechoic fluid is blood fluid.
Very
Can
nice.
because it's not a blura, it is it is space filled by secretion. Could I call blood effusion or hydrothorax?
So that's a really good question, and I know that we raised it last time. So by definition, sir, I would say that uh, fluid has to be within the visceral and parietal layers of the pleura. Now, when you have a diaphragmatic hernia that's been repaired, you've pushed the bowel down, and whatever remnant lung there is will expand, and that expansion will vary depending on the degree of lung hypoplasia. If there is very severe lung hypoplasia, then the pleura is usually hypoplastic and it's adherent to the lung nubbin. Now, if that is the case, then most of what you see is fluid accumulating in the thoracic cavity. Some of the fluid that's been secreted by the bowel while it was there, some of it is just exudate that replaces any air that's left in the chest. Now, some people like to call that a hydrothorax. It depends on how hypoplastic your lung is. If your lung is not so hypoplastic, as you might find with postnatal cases of diaphragmatic hernia, often the whole lung expands and you have well-developed pleura. Now, in those cases, it's not unusual for you to develop fluid within the visceral and parietal spaces. In this situation, I cannot make out the difference between visceral and parietal pleura at all. I can say that there's a diaphragm there. Doesn't look like a patch because it's not very bright, but this would just be fluid in the intrathoracic space.
he didn't need a patch. He just بس
Yeah,
repair,
yeah,
بعمل repair.
yeah. So, but again, a beautiful image of what you can see is lung that's expanding into it. So very nice, sir.
Next presentation, inshallah, next week, I will do this conduct hernia before repair.
Yeah, just very nice images, sir. Can I just say very nice depth penetration, 3.5 centimeters, a very good clarity. I'd say your gain is perfect. I would not be changing your gain settings. Uh, just maybe a little bit of playing with the frequency if you want to see a little bit more depth, but very nice images, sir. My compliments.
This is right anterior upper because in the forensic hernia now there is a score called the CDH lung score, LUS score. I made it right and left would make a score, but inshallah will next presentation the forensic hernia I will talk about this.
Sure.
This is normal lung pattern.
Yeah,
The
very
back wing
nice.
signs is
Very nice.
pleura. It is rib pleura sliding. في comital here.
Yeah,
في lines. This is normal pattern.
yeah, I agree. Beautiful.
The same R1. This is R3 and 4. Here some dollar line, some B line here.
Yep.
I think more than two. This is score one.
Yep.
This is my more than two.
Yeah, more than two. I would say that you probably have a few that are coming together. So definitely more than two in that intercostal space. But well aerated lung below that. So kind of what I'd say is a double lung point coming in.
This is the difference between this is the image by camera. It is a barcode sign here. Because it's by camera this one.
Yep.
This is pneumothorax here barcode. This is normal along the right side and left side.
Very nice.
This is an X-ray before repair and after repair. This is pneumothorax. This is the area. This one.
Yeah. Very nice.
So summary of finding: the right lung normal pleural line, normal lung sliding, presence of A line, absent to B line for all area, except one area, one space have one lung score one, but they have B line.
Yep.
Left lung, we have normal pleural line, absent lung sliding in all area, presence A line, no B line, mirror drip, moderate pleural fluid at posterior lateral area with barcode sign in M1.
Yep.
The diagnosis was the pneumothorax.
Left-sided.
What is the diagnostic criteria of pneumothorax? بالبي مود اللي هو البرايت مود. We found absent lung sliding should be absent lung sliding. Presence of A line and absence of B line. Presence of lung point in mild to moderate cases. Track sign or mirror drip. Absence of lung pulse. والستراتوفير or barcode بالام مود.
Lovely. Well done.
This is بس عشان this is tricky عشان I tell my colleague should be know the where the scan يعني scan the lung or not the lung. This baby is sudden deteriorated. I made an ultrasound. We found this nice lines with see the lung sliding here, no lung sliding here.
So is that
But
stomach?
if you look,
No.
yeah, if you look here, there is no rib. It's no rib. When I do
Questions with its
because
bowel.
the
Yeah.
baby collapsed, I did distended abdomen. I did X-ray to pneumoperitoneum. When doing a scanning for crash baby in the lateral border, the lung is okay, but the a lot of air in behind. In X-ray, I show to you. This is the barcode here. and the normal lung here barcode from the stomach, from the air.
So very important. It's right lateral. So that's a really good point. But I think Dr. Ashraf is demonstrating very nicely what happens when you go into the lower regions, and we will have cases that we will show you. On the left side, you get the stomach. On the right side, you can get bowel, but more importantly, you can get free air and perforation. And some of the signs of a perforation in the abdomen, when you look at it, because air tends to rise anteriorly, when you get into the lower lobes of the lung, if you kind of see what is an A- profile with no sliding, as you can see with the image on the right.
Yeah, this one,
Yeah.
this is the stomach, this is the air in the abdomen.
Yeah. So the differentiating point is there'll be absolutely no batwing sign. And just
Yeah,
what I like to do, if you all look at me, this is really important. Sometimes you can get an overlap of the ribs. So can you see my phone? So what I like to do is I like to press with the probe. And if I press with the probe and I kind of am in an area where there's absolutely no batwing sign and I can see something like that, well, I'm either seeing the stomach, which is full of air, if it's on the left side, but if it's on the right side, that might be bowel. And if you can't see, what I would say is any kind of movements, no peristalsis, complete stillness with that kind, then that could be free air. And another good marker of free air anteriorly is that for those of you who do echocardiography, if you try to see the aorta, in particular, when you try to do the situs view, you will not be able to see the aorta because you'll have air in the interface. I have diagnosed lots of spontaneous perforations, but unfortunately for the baby, like that. So it's a really good example. The importance of this slide is, again, just be very careful as you move down, because you can easily confuse a pneumothorax, with what is just the stomach. The most important thing is being able to demonstrate the batwing sign. Thank you so much, Dr. Ashraf. Beautiful images. We're so grateful.
thank you,
Learned so much. Does
thank you.
anybody have any questions before we move to Surjit's slides? No questions? So I apologize to some of you, you were in the waiting room. Can I just say, guys, really, really important for the peer review sessions, really important to be on time, because once we start discussing the cases, it becomes a little bit difficult for me to let you in. The other thing that I will do for the next peer review sessions is I'll probably make somebody else co-host, because I know that some of you sometimes go in and out. Surjit, would you like to share your case?
Yeah, I'm sharing.
God bless you. So, Dr. Ashraf, where do you work? Just while Surjit is sharing her images.
In United Doctor Hospital in Saudi Kingdom in Jeddah.
Amazing. Surjit, just introduce yourself, and once you're ready, go for it. Can you hear us, Surjit? Surjit, I think we've lost you. Can you hear us? Does anybody else have any cases they'd like to share just while Surjit is coming back on? Do you have any questions just while we're waiting for Surjit?
Alok, hi, it's Satish
Hi,
from Luton.
Satish. Hi, how are you?
And if
Hello,
I'm
hi.
okay, thank you. Oh, sorry. If Surjit is ready, then I'll let her go. If not, I'll ask.
Surjit, are you? I think she's still muted. Go for it, Satish. Yeah.
Yeah. First and foremost, I'm thoroughly enjoying, this course. So I've got some transferable skills. I do cardiac ultrasound. I've been doing this for many years. So I've already put the probe and started doing lung ultrasound. I've done 15 odd cases. I put the logbook.
Yeah.
I'm just struggling to upload onto the the logbook, insert, etc.
So don't worry about that. Save your cases numbered 1 to 15.
Yeah.
And at the end of the course, what we will do is we'll insert your cases for you.
Okay. Yeah. I mean, I've anonymized. I've saved it on my computer. They're all there, ready to go.
Yep.
Most of them are kind of well babies for the time being,
And-
odd TT and things like that.
And
Okay.
what I'd say is just a little bit of background, one slide each, makes it really easy. Some of you have kind of uploaded just completely blank. So I have no clinical background. And if it's a normal scan, that's great. But if it's not a normal scan, not you, Satish, it's just for the others. Just one slide with background on it really helps me.
No, that's good. I have
Got-
put in my own kind of a logbook with
Sure.
a Excel sheet. So for my own learning, so I've got the background details. I've got some of them. I've got chest X-rays. Okay, that's fine. So I'll just keep going what I'm doing for the time. Shall I?
Perfect. And you don't have to use my logbook. You can use your own logbook. You can have an Excel sheet. You can keep, so whatever works for you. The main thing from my perspective is I will, if you let me know and you're using any of your logbooks and you need me to have a look, I'll have a look at the images and then initial yours. So please let me
That's
know.
fine. No, that's fine. I'll just keep going. I'll just keep the logbook. I'll store the images, and then towards the end, then you can review and give me the feedback. Yeah. Thank you.
Surjit, are you okay to share again?
Yeah. I'll
Have a
share.
go. Don't worry. This during the learning phase, it's quite common. So don't feel anxious. Yeah. Amazing. We can see your screen.
Mm.
Yep. Beautiful.
Yeah, am I audible now?
Audible and visible.
Yeah. This is a lung ultrasound of a term baby, 37-weeker. It was an IUGR baby and also had early onset sepsis and thrombocytopenia. And the birth weight was 1.3 kg. Baby was born by LSCS and was just on oxygen support. At birth, didn't have much of respiratory distress. So baby was only on oxygen. And there was a history of hypertension, sepsis, and oligohydramnios in mother. So baby was quite stable on oxygen, and on day 3 suddenly deteriorated and had desaturations, and the respiratory distress increased, and baby had little bit of GI bleed also. So we had to immediately intubate the baby, and we put on mechanical ventilator. And we then did an X-ray and lung ultrasound also. So I'll show you a few videos. So this is a machine which I use. This is Sonocyte M Turbo. It's a portable machine. And the probe which I use is 6 to 13 hertz frequency, and it's a linear probe.
Lovely.
Yeah. So this was an X-ray which we did. And then I did a lung ultrasound. When the baby suddenly deteriorated, I thought maybe it must be a pneumothorax, or let me just see what is the cause of desaturations.
Ji.
And I actually took this from my phone, so the upper part is missing here. But we can still see 3 ribs, 1, 2, and 3, and I think 4. And I can see intercostal spaces, 1, 2, 3, and 4th intercostal space. And so when there is no acoustic shadow, we can't say that there is a batwing sign. Like, how do we
No. There is a
mention
batwing
that?
sign. So the idea from our perspective is you can
Because
see ribs
2
there
ribs.
and you can see
Okay.
pleura in between. So if I just annotate it for
Yeah.
you, just
Okay.
yeah. So basically
So
that's
the
a rib,
batwing sign is seen.
that's a
Yeah.
rib, and that's the pleura. So that's the batwing sign for you. That
Okay.
basically identifies that you're in the region of the lung and the intercostal spaces. Yeah. It's a
Okay. Okay.
beautiful image. Carry on.
So I can see 4 ribs, 3 intercostal spaces, batwing sign is seen, and the pleural line is discontinuous and irregular, disrupted at few places here and here, and the lung sliding is present. So I can see B lines, which are confluent B lines, and in between few of A lines are also seen, and there is subpleural consolidation. Like, do we call this subpleural consolidations or the shred sign? I was like
No,
little confused what you actually
you're absolutely right.
said.
So the one thing that I'm going to teach you today is a concept called mental modeling. So mental modeling kind of, whenever you do MCQs, usually your first guess is your best guess. So morphologically, whenever you see an image, the mental model that you form first is usually quite accurate. You do have subpleural consolidations. So this region here, there, these are all subpleural consolidations. I would say that at the moment your pleura is regular. You can see it in entirety, except in this region over here. It is
Yeah.
continuous,
And here,
except in this region over here, and it is thick and blurred. So you're right. I think saying discontinuous, it's just that region there that really makes me feel it's discontinuous. And you're absolutely right. You
okay.
can see some A lines coming in there, but really what is, so if you were to class this as a profile, so where is this first? Which region? R1? Right?
Yeah, actually, somehow I have not been mentioning the regions, but yes, this is R1,
Lovely.
right side. Yeah.
Okay, so in terms of kind of, you've got a batwing sign, describe the pleura. Now, you've classically said this is kind of lots of B lines, some A. So, but if you were talking about a profile, what would you say for this
It's
region
B
and R1?
profile.
Beautiful. I would agree completely. Can I just say it's a very nice image, ma'am. You have really good penetration. I can interpret everything right down to the bottom in a very uniform way. Even with a little bit of speckling at the bottom, you get very good image delineation. I would say the gain settings are good. They're optimum. There's nothing that I would say you need to
Yeah.
do to optimize this image. Well done, ma'am. Carry on.
I had a query, like
Ji.
what we usually discuss, that the depth has to be 4 to 5 centimeters. So, but I get my images clearly when the depth is around 2.6 like this. So,
Yeah.
if I increase the depth to 4 to 5, then this area gets very narrowed.
Very good. Very
So,
good.
what
That's
would be
beautiful. So
appropriate?
you're using a linear probe, and as you increase your depth, the footprint. So just for everybody, guys, look at me. So this is your linear probe. Okay. Now, when your linear probe is like this, and you kind of are giving sound waves down, what happens is that if you increase your depth, the the a lot of the probes will basically give sound waves in a very focal region, which means you lose the length of the image that you see over here. So just go back to it. So I've lost my annotate. Now, the way around that is you need not to actually increase or decrease your depth. Stay at 4 centimeters and use your frequency. So the frequency that you're using is quite high. Now, because are you using a frequency that's 12 to 14 in this baby? Surjit, can you hear me?
Yeah, I can hear
Yeah.
you, but the
So
voice is breaking.
yeah, just in terms of the frequency you're using, is it on the high side?
Okay.
So what I'd say is that to avoid losing your footprint, to keep the image where you'd like it to be, so I'm just going to use my annotate again. So this length gets shortened when you increase your depth. So what I'd say is if you set your depth already to 4 and you play with your frequency, reduce your frequency, then what will happen is you'll get good image delineation. What gestation was this baby?
This is 37 weeks. maybe.
Yeah. So
But
what I'd say is
severe eyes,
that the
yeah.
risk of using just 2.5 centimeters, you'll be missing out on a lot of the deeper anatomy. So you really need in a baby that gestation, who's that weight, to have a kind of a depth of minimum of 4 to 5 centimeters. And if you're losing the distal end here, my advice would be drop your frequency. Play with it. If you're using a frequency of 12 to 14, come down a little bit, and that will give you better, I would say, delineation of the deeper anatomy, whilst you are not losing your footprint. Okay?
Okay.
Does that make sense?
Yes,
The
yes.
Sonosite is a beautiful machine. It'll let you do all of that. Oh, very nice image. Yeah, carry on.
This is another region. I am actually not sure which area, which region this is, because I have not noted down. So
With a rough
in
guess,
this,
which region do you think?
definitely this must be right anterior, so this must be right axillary or region. So R3, R3, R4.
Okay, carry on. Yeah.
Yeah, so here I can see the bat wing sign, and I can see 4 ribs and 3 intercostal spaces. And here I'm not able to appreciate pleural line.
Beautiful.
So can you, there is a B profile and there are no A lines. Very a few here and there I can see A lines. Otherwise, here I think I can tell this is a shred sign. And how do I mention regarding these bronchograms, ecogenic areas? Should I mention these as bronchograms, or like static or dynamic? I'm not very sure
Okay.
about this, but I think there's shred sign present.
Well done, first of all. So can I just say image quality is very good again. Got good depth penetration up to a depth of 2.5 centimeters. What I would say is that just going by structure, again, rib, a little bit of rib shadow that you see over there. So a kind of a batwing sign. You can see 1, 2, 3, 4 possible intercostal spaces with 4 ribs. Now, just coming back to the pleura, you cannot see the pleura. Now, the reason you
What
can't,
is this? What is this?
so really what I'd say is that is soft tissue, superficial layer. This is all
Okay.
soft tissue. This is soft tissue.
Okay.
And really, what is happening is that you have a baby who's got a B profile, but the pleural line is not established because this is all atelectasis. So you're not getting any air in. So this is basically a B profile. Okay, you have lots of consolidation over here, and with the consolidation, you have these small areas which are static air bronchograms. But because this lung is not aerated, what is happening is you're not getting any pleural line established. This is all atelectasis. If I was a betting person, I would probably say this is a baby where you're trying to get the back of the baby, possibly through the posterior axillary line. And that's why you're not quite straight. You have a lot of soft tissue. And my gut feeling is this is probably the back of the lungs. This is probably R5, R6. And you have a lot of atelectasis at the back. So it's because your lung is not well recruited at the back. I mean, when I look at your initial image and this image, really the mental model that I'm kind of getting at this particular point is this is not a fractal sign. The reason this is not a fractal sign is because this entire area is atelectatic. This entire area is atelectatic. It's not irregular. So you don't have pleura. So normally with a fractal sign, you'll have this pleural line, which is very irregular with a subpleural consolidation. Actually, this entire area is just off the lung. This is the established lung line, and there's no aeration here. So it's a beautiful image of what I would say is, I think RDS with lung atelectasis is the mental model that I'm forming. But just remember, we've only seen 2 regions. We haven't seen all regions. And in this baby, I would be doing a comprehensive scan. But very nice images, very good image quality. Just for a term baby, you'll need more depth. You need to be at least 4 centimeters. And if you're losing the deeper area of your lung over here, then what I would do is I'd take one of these views and I would reduce my frequency so that I get better depth penetration without losing my footprint. Does that make sense?
Oh,
But
yes,
it's a
yes.
beautiful image. Carry on.
Can you just clear this?
Yeah, I'm just doing that. Yeah, just taking my rubber out. Find the damn thing. Yeah. Sorry. I have a bad habit of drawing. Carry on. Yeah.
Yeah, so this is left side ultrasound image.
Yeah.
I'm hoping this is L1, L2.
Okay.
So here I can see 4 ribs, 2, 3, and 4, and a bit of fifth one, and can see 4 intercostal spaces, 1,
Very good.
2, 3, and 4. And again, here I'm not able to appreciate the pleural line. And there, I think I can say it's a B profile and subpleural consolidation.
Very
Not
good.
very sure. I call it as subpleural consolidation.
So
And
you're
there are no
absolutely
A
right.
lines seen. Yeah.
Yeah, you're absolutely right. Very nice. I don't have anything to add. My only comment is that when you compare the two sides, you have a lot more atelectasis here. Over here, what I'd say is that you have some element of aeration. So that bright area that you're looking at is just a little bit of pleura that's being established, but you have a lot of subpleural consolidations in this region. You have some static air bronchograms coming in. Can you see this area here? That's a static air bronchogram for you that just moves in and out. And really you have a B profile. It's very uniform. Again, the impression that I'm getting is looking at the different regions, it's a very uniform kind of involvement of the lung. So carry on. Yep.
No, these are the only 3 images of
Beautiful,
this
beautiful.
baby
And with the
which
rest
I
of the
had.
images very similar?
Yeah, they were all similar ones.
Okay.
I actually thought the diagnosis as a pulmonary hemorrhage here.
It's
Not
possible.
very
What
sure
was, but
because
were you getting blood up the ET tube?
yeah, we got blood also.
Okay.
And because I have not done lung ultrasound on day 1 because the baby was very stable and was just on oxygen.
Okay.
And suddenly on day 3, baby deteriorated.
Yeah.
So I took it as I've not given surfactant also for this baby.
Sure. That's great. Just going back to it again, just mentally modeling that history of pulmonary hemorrhage is very, very important because if I don't have the history of blood up the ET tube and it's an acutely deteriorating baby, I might think that's just RDS that's getting worse, where we've intubated, ventilated, and we haven't recruited enough lung. And one of the options would be going up on pressure. Now, that could be going up on PIP, PEEP. It could be giving another dose of surfactant to this baby. But the fact that you've said that this is a pulmonary hemorrhage, I mean, for me, really, what I would say is recruitment would be a very important maneuver in this particular process. And I would be going back. Now, PEEP is the most common thing that you would increase in this situation. I would be repeating a lung ultrasound in this situation to review and see that I've recruited lung. And that would be through the establishment of the pleural line. And basically what you'd be able to see is maybe a compact B profile, maybe some A with B profiles. So very nice images. I don't think there's anything that I would do to optimize those images as they are, other than that for a near-term baby, you'd really need to have at least 4 to 5 centimeters of depth. And to avoid losing your footprint and that problem of your image becoming really small, I would play with your frequency. So if you're
Okay.
using a higher frequency, you can reduce it. Carry on.
Okay. This is another case. This is a term baby who presented with who was with me with respiratory distress, and there was a history of severe birth asphyxia. Baby also had moderate PPH and was in shock, was LSES born. It came from outside. It was an outborn baby. And with me, baby was on mechanical ventilator. And again, there was sudden deterioration with desaturation. So this was a X-ray of the baby. And when I did a lung ultrasound, this was a image. And I can see two ribs here, and this batwing sign is seen.
Yeah.
This is a pleural line, and there was absent lung sliding, what
Very good.
I thought.
Very good. Yes, I would
And
agree.
it's an A profile, A dash profile,
Yep.
can say. And
Yep.
there are no B lines. Then I put a M mode in this area, and this is what I got.
Beautiful.
This is a barcode sign.
Yeah.
With the barcode like horizontal. Dr. Alak, I want to ask, what are these? Are these T lines?
Now it's a little bit of lung pulse. It's
Lung
just a little
pulse.
bit of lung pulse
Yeah.
that's coming through. Yeah.
Right. These T lines are seen in lung pulse
Yeah.
because usually, not all the time, you can see
So
these
is that the
lines.
left side of the baby? If that's the left lung, is that a left-sided
Yes.
pneumothorax?
No,
That's
it's
the
the
right
right
side.
side.
Okay. So
Yeah.
basically, you've got this area of completely collapsed lung. So what you might be seeing is the heart moving that collapsed area of lung, which gives you that kind of artifact. But classically, I mean, batwing sign, I can't see any sliding here. I can just see what is probably respiratory movement with the ventilator.
Mm.
And really, this is a classical A dash profile. Again, my only comment is this is 2.6 centimeters. Is this a term baby?
Yes, it's a term baby.
Yeah. Try to, when you're setting your parameters, start with 4. Start
Okay.
with 4. And I know what's happening. When you put the probe in, you basically have complete dropout. There's nothing visible, as you can see over here. So just for everybody else who's watching, I'm just going to annotate, yeah, this area here to kind of say that you're basically losing a lot of architecture over here. And the reason for that is you're using a high frequency which will concentrate on the more superficial areas. Now the sonocyte again does not need, you don't need to optimize focus. The focus at every level is auto optimized in the sonocyte machine. So really what
Yes.
I would say is you just need to reduce your frequency a little bit, and what you'll get is better delineation of the entire region without a loss of your footprint. So that is the only thing. This is a beautiful image. My compliments. I wouldn't be able to do better.
Yeah.
Well done.
Thank
ma'am.
you.
Well done. Lovely. Is that the cases you have to share? That's amazing.
Yeah. I
Thank you so
have
much.
cases that I have not put in the logbook. I'll drop them later on.
That's fine.
Yeah.
We're very grateful. We're very grateful. You know, it's really helpful. Does anybody have any other cases they'd like to share? Okay.